The following podcast is part of a certified educational activity titled Charting a New Course in Limited Stage Small Cell Lung Cancer Amid an Immunotherapy Sea Change, Elevating Curative Intent Treatment Approaches. Access the entire activity and complete the post-test at peerview.com/ZPF860. Downloadable slides and practice aids are also available.
Hello, my name is Dr. David Spiegel. I'm the Chief Scientific Officer at Sarah Cannon Research Institute in Nashville, Tennessee. It is my honor to present limited stage small cell lung cancer amid a sea change brought on by immunotherapy. So my goals for today are to cover these areas: to equip you with knowledge about the latest evidence on and guideline recommendations for the use of consolidation immunotherapy in limited stage small cell lung cancer, to enhance your skills in devising multimodal treatment plans inclusive of consolidation immunotherapy for patients with limited stage small cell lung cancer, and to augment your ability to address practical aspects of the immunotherapy inclusive treatment in limited stage small cell lung cancer, including timely initiation of therapy, optimal administration, and proactive management of immune-related adverse events. So we can all agree there's an unmet medical need in the treatment of limited stage small cell lung cancer. Limited stage disease is classified as small cell lung cancer that is generally only in one lung or on one side of the chest. And limited stage disease accounts for approximately 30% of all small cell lung cancer diagnoses. So what are the key unmet needs? Well, first, the urgency of diagnosis. We know that this disease is rapid, aggressive. Patients often present with aggressive, advanced, or what we say extensive stage disease. So when we find limited stage disease, we know there's a chance of cure. But even with modern combined chemoradiotherapy standard approaches, there is a poor prognosis. Only 15 to 30% of patients with limited stage disease will be alive 5 years after diagnosis. And we know there's a role for immunotherapy in the treatment of extensive stage disease. This was established from two large randomized trials. First, we have Empower 133. This proved that the addition of atezolizumab to platinum etoposide chemotherapy improved overall survival without significant toxicity. This led to the FDA approval of atezolizumab in the first-line extensive stage setting in March of 2019. And then we had the Caspian study in another randomized phase 3 trial that showed the benefits of adding durvalumab, a PD-L1 antibody, to first-line platinum etoposide therapy. And this showed an improvement in overall survival, also without significant toxicity. And this led to an FDA approval in March of 2020. So the use of immunotherapy in extensive stage small cell lung cancer has been a standard of care for many years now. But where do we go next with immunotherapy in small cell lung cancer? Can adding radiation to immunotherapy improve outcomes in extensive stage disease? And can we benefit from the use of immunotherapy in earlier stages of small cell lung cancer, such as limited stage disease? And so we now have trials that are starting to answer these questions. The first main study is the Adriatic trial. So this was a randomized phase 3, double-blind, placebo-controlled, multi-center study for patients with limited stage small cell lung cancer. This trial included patients with limited stage disease, stages 1 through 3 that were inoperable, patients with good performance status, and importantly, patients who had received combination chemoradiotherapy, had finished that, and had not progressed. The use of PCI or prophylactic cranial radiation was permitted but not required before randomization. And all patients were stratified based on stage and whether or not they received PCI. So again, patients all had limited stage disease. Patients had to have received platinum etoposide, up to 4 cycles of therapy, 3 were allowed. Radiation therapy could have been given in a standard 60 to 66 gray daily over 6 weeks, or 45 gray BID over 3 weeks. And radiation must have started no later than the end of the second cycle of chemotherapy. All patients were then randomized to 3 arms: to immunotherapy with durvalumab at 1,500 milligrams IV monthly, to a placebo, or to a combination of durvalumab and tremelimumab, a CTLA-4 antibody, given monthly for 4 doses, followed by durvalumab given monthly. This study had dual primary endpoints to look at the comparison of durvalumab versus placebo in terms of overall survival and progression-free survival by blinded independent central review. And there were important secondary endpoints for the combination arm with tremelimumab, again for survival and PFS, and then other endpoints such as PFS landmarks and safety. All treatment continued until investigator-determined progression or intolerable toxicity, or a maximum of 2 years. The analysis that was presented at ASCO and was in the New England Journal publication we'll show shortly was focused on the comparison of durvalumab versus placebo, those first 2 arms. And the primary endpoint of overall survival was met, as shown here. So the median duration of follow-up was approximately 37 months. And as you can see here, there was an advantage for survival with durvalumab compared with placebo. The median survival for durvalumab approached 56 months compared with 33.4 months for placebo, with a hazard ratio of 0.73, or said another way, a 27% reduction in the risk of death with a p-value of 0.01. And you can see the landmark analyses at 24 months and 36 months. If you look at the forest plot for survival and you look at the subsets, whether by age, gender, race, performance status, or the time of initiation of the study in terms of end of chemoradiotherapy to randomization, and even things like platinum choice, some patients could have received carboplatin etoposide, some patients could have received cisplatin. The advantage for survival appears to be sustained across all these subsets, even when looking at things like radiation schedule. Remember, I mentioned you could have received it daily at your institution or BID, and PCI use. I know that's been a controversial subject we can talk about a little bit later, but whether patients received PCI or not, the survival advantage was in favor of durvalumab. Recall this study had dual primary endpoints for this analysis of durvalumab versus placebo. And again, the median duration of follow-up in this PFS analysis was about 27.6 months. The advantage was in favor of durvalumab. So the median PFS for durvalumab was 16.6 months compared with 9.2 months for placebo, with a hazard ratio of 0.76, or a 24% reduction in the risk of progression or death, and a p-value of 0.161. And again, you can see the landmark PFS endpoints here at 18 months and 24 months, a consistent advantage in this case for PFS in favor of durvalumab. When you look at the forest plot for the subsets for PFS, it looks like the overall survival forest plot. There's not one subset where it looks like this advantage for durvalumab is not sustained or seen. And so that is reassuring. This appears to apply to all the patients that were included in the randomization. Just a word about exposure and safety. So the median number of doses for durvalumab in this study, recall the goal was to receive 24 months or 2 years of durvalumab, but the median the median number of doses was 9 in the durvalumab, and that was comparable to the number received in the placebo arm. The mean was just under 13 months compared with just under 12 months. If we look at any grade all-cause adverse events, those rates were 94% in the durvalumab arm compared with 88% in the placebo arm. And if we look at serious adverse events, those rates fall to about 29.8% versus 24.2%. One of the big questions, though, is how much toxicity leads to bad outcomes where you stop the study, treatment, and of course, the worst outcome, death. If we look at those rates, it's 16.4% of patients had adverse events or toxicity leading to treatment discontinuation versus 10.6% in the placebo arm. In AEs, specifically treatment-related AEs leading to death, those numbers were quite low. There were just 2 absolute events compared with 0 in the placebo arm. And then a word about immune-mediated adverse events. If we just focus on the severe grade 3-4 immune-mediated adverse events, those rates were 5.3% versus 1.5%. Always kind of interesting when you see severe immune-mediated adverse events in a placebo arm. Here's a tornado plot. I think that maybe better depicts the safety profile for durvalumab, shown in blue on the left, placebo on the right. The darker kind of shades to these bars are the all-grade toxicity, and then you can see the lighter shades reflect the more severe grade 3 or higher toxicity. So, for example, radiation pneumonitis was seen in approximately 23% of patients with durvalumab. But if you look at placebo, that number is basically the same, 23.4%. And then if you focus on severe toxicity, which we'll talk about a little bit more, it's a very small percentage of patients. And if you look across the board at hypothyroidism, pruritus, things like pneumonitis, otherwise rash, things that might be regarded as immune-related adverse events, those rates really are quite expected and low and not unusual for the use of a drug like durvalumab, and you can compare that with placebo. I think my take home from this slide is the rates are what we expect, certainly for radiation pneumonitis following chemoradiotherapy in all patients, and the severe rates of toxicity, I think, are relatively low. So what are the conclusions? When durvalumab is used as consolidation treatment after combined chemoradiotherapy, Adriatic demonstrated a statistically significant and clinically meaningful improvement in both overall survival and progression-free survival compared with placebo in patients with limited stage small cell lung cancer. The overall survival hazard rate was 0.73 with a significant p-value of 0.104. And as I mentioned, a median overall survival of 55.9 months compared with 33.4 months. This advantage was true for PFS as well, with a hazard ratio of 0.76, with a p-value of 0.0161, and median progression-free survival of 16.6 months versus 9.2 months. And I think as impressive as those dual endpoints are, it's equally gratifying to see treatment benefit was consistent across patient subgroups for both overall survival and progression-free survival. Durvalumab consolidation treatment for up to 2 years was generally well tolerated, and the safety findings were really consistent with the known safety profile of durvalumab monotherapy following chemoradiotherapy. And so these data support consolidation durvalumab as a new standard of care for patients with limited stage small cell lung cancer who have not progressed following combined chemoradiotherapy. And indeed, this led to an FDA approval that was issued recently, December 4th, 2024, where the label is that durvalumab can be used for all adults with limited stage small cell lung cancer whose disease has not progressed following concurrent platinum-based chemoradiotherapy. So let's talk a little bit about kind of how patients did on this study in terms of patient-reported outcomes. So I think we all kind of understand the way this study was designed, but it's important to note that patient-reported outcomes, or what we call PRO data, were collected until the second disease progression or the study end. And what was found from these analyses was that, number one, the mean changes from baseline in pre-specified key subscales were small and not clinically meaningful in either arm. So in other words, no clinically meaningful difference between treatment arms was observed, suggesting, I think, that patients were not harmed on the experimental arm. There were similar improvement rates reported in both arms across most of the subscales, and a higher improvement rate for chest pain was seen in the durvalumab arm compared with placebo. And importantly, there were no differences in time to deterioration seen between the two arms, except for perhaps arm and shoulder pain, which was delayed with durvalumab versus placebo. And so in conclusion, in Adriatic, durvalumab improved survival outcomes versus placebo without compromising patient-reported outcomes for quality of life, functioning, and symptoms. These data further support the use of consolidation durvalumab as a new standard of care for patients with limited stage small cell lung cancer. There are also some additional outcomes that have been shared this most recently by Dr. Sanan at ESMO. This was a post hoc analysis to look at durvalumab versus placebo subgroup comparisons based on PCI use and some prior chemoradiotherapy variables. So recall in this study, you could have received radiation in two different ways, in a daily schedule or a BID schedule. And I think just depending on where patients were enrolled globally, some centers choose one over the other. So that was left up to the investigator. And then, of course, remember, PCI use was optional. In this study, we didn't have time to go into that earlier in the primary presentation, but now I can show you that if you look at the intent to treat population and you ask the question, who actually received PCI, and remember, this was a stratification factor, so we would expect equal numbers. And so the rates were basically about half, 54% of patients in each arm received PCI. The way I like to look at that is about half of the patients did not receive it. So that's important. And then kind of an old question is, which platinum agent did you use? Some people feel very strongly that cisplatin is the drug you should always use in a curative setting. But the truth is, we know carboplatin is used commonly. And in this study, about a third of patients received carboplatin and 2/3 received cisplatin. And then if you look at the radiation schedules, most receive daily therapy on a daily schedule. The twice daily administration of radiation was seen in about 26 and 30% of patients, respectively, durvalumab placebo arms. And that kind of fits with what we would expect. I mean, most centers are not equipped to give BID treatment. It's not the most convenient way to give radiation therapy for patients. The analyses I'm going to show you for overall survival, PFS, and safety were based on these subgroups of PCI versus no PCI in the radiation schedule. And so this was what was presented at ESMO by Dr. Sanan. If you look at PCI, yes, as shown on the left, and PCI, no, remember it was 54 and 46% respectively in terms of who received PCI or not. And you look at the overall survival, here are the outcomes. And I know it's a complicated slide here. And remember, blue is the durvalumab arm, and orange here is the placebo arm. So if we look on the left for the moment, we can see that the advantage for durvalumab is sustained in patients who receive PCI compared with placebo, 62% at 36 months versus 56.5%. And if you look at those that didn't receive PCI, remember the 46% of patients that did not receive PCI, this advantage holds true. It's a 50% 36-month overall survival versus 37.3% survival. So what is the kind of take home there? I think the take home is kind of what I showed you in the forest plot for survival. That is to say, whether a patient receives PCI or not, durvalumab leads to a survival advantage over placebo. Now, some could argue, isn't the 36-month survival, doesn't it appear better, 62% versus the 50% mark, kind of getting into this argument about PCI, shouldn't patients get it or not? That's not really what this analysis is intended to prove or disprove. It's just to show if you use PCI or not, which was allowed in the trial as a choice of the investigator, you can feel comfortable that the advantage with durvalumab is maintained. And if you look at PFS, this holds true, and I'll just kind of go through this more quickly. Again, PCI yes on the left, PCI no on the right, and blue is Durva. You can see that the advantage for durvalumab is maintained. Again, I think a separate question is does PCI use lead to better outcomes? As you can see here, 54.6% and 37.1% at the 24-month landmarks. I think that's a separate conversation, a separate question that you learn a little bit from these subset analyses, but this trial was not designed to show that PCI was better with durvalumab versus not getting PCI and getting durvalumab. But I think these are interesting questions, and my guess is we'll be revisiting the PCI question still in the years ahead. If you look at my probably least favorite question to ask is, does it matter which platinum therapy you use? This kind of analysis holds true. And I showed you this in the forest plot so that if you got carboplatin, the advantage for durvalumab was there. And if you got cisplatin, the advantage for cisplatin was there. Now, interestingly, this goes in the opposite direction of common thinking. That is to say, I think most people would say, and I'm not one of them, but most people would say that cisplatin is the better drug to use. It gives you a better chance of being cured. This would suggest that's not true, that durvalumab is a good thing to do if you use cisplatin, but you kind of get the sense here that carboplatin leads to better outcomes. Kind of a big surprise, I think, to show in a study. It's actually my preference for the treatment of limited stage and extensive stage disease. It's just easier for patients, in my opinion. And then if you look at PFS, it holds true too. So again, the advantage for Durva, this is what I showed you in the forest plots. It doesn't really matter if you got carbo or cis. It's kind of your choice. Again, there's some hints here that maybe carbo is better, but this study was not designed to show that. And then kind of an interesting question, because we do have data that show BID radiation schedules, are better than daily schedules. It's just they're not practical at most centers. And so it's important to ask this question, like, does it matter in the case of Durva? And so this is a complicated slide. The numbers get really small here. But, I think if you look at the graphs, you would say that BID schedule still is a good way to use radiation. If you're going to use Durva, you get the advantage. I think the daily schedule looks cleaner. It separates from the beginning. You don't have this crossover in the beginning. But again, I think that the high level take home from this slide is that in this presentation is that, you can continue to give radiation in the schedules that work best at your center that you prefer, BID or daily. Durvalumab will still be associated with that advantage. The numbers are small. The hazard ratios do cross one for the BID schedule, but I think the overall impression is that this is a good thing to add. And again, for PFS, the same is true. So I just showed you a lot of different slides for OS and PFS for not only radiation schedule as shown here, but platinum use and PCI use. And across every one of those slides, the advantage is in favor of durvalumab. If you look at, get into some weeds here, and you look at the same kind of subsets, chemotherapy choice, PCI use, radiation, and you look at maximum grade treatment-related adverse events and those that lead to treatment discontinuation, you can see that these bars, in general, look consistent, but there are some subtle differences. So, for example, if you look at the PCI side, on the far left there, if you got PCI, you have more toxicity. We don't describe what those are necessarily in this slide, but, not a surprise, right? PCI is hard for folks. If you look at carbo, the toxicity rates are higher than with cis. That is a surprise to me. The radiation schedule, actually looks to be a little bit safer with BID scheduling. But if you focus on just these maximum grade 3-4 events, yes, there's differences in whether you got PCI or carbo or BID radiation. But if you look at the differences between whether you got Durva or not, then there really are not any large gaps there to make up in terms of placebo versus Durva. I think they look pretty comparable. If you switch to the other side and you ask the question, well, what about treatment discontinuation? There is some separation there. And these numbers get kind of small here, but you're talking about patients that actually stop treatment because of these toxicities. So again, not to get too far into the weeds here, but for example, if you look at patients who did not receive PCI, Durva is associated with more treatment discontinuation, kind of an interesting, I don't really have a good explanation for why that would be. If you look at choice of platinum therapy, there's, more platinum discontinuation with Durva in both cis and carbo. But that's not a big surprise versus placebo. And then on the BID schedule, there's a little bit of differences there between Durva and placebo in terms of side effects leading to treatment discontinuation. But I think they seem consistent across the board. The only thing that looks a little bit weird is the PCI use. Let me just mention this trial quickly because we got this news in the summer of 2024. We got the FDA approval for durvalumab in limited stage disease following chemoradiotherapy just recently at the end of 2024. But this study, which hasn't made a lot of press, we've heard something about. There was a press release, but and some data were presented recently. But this is the NRG Alliance chemoradiotherapy trial. It looks like Adriatic, but there are some differences. Number one is it's a TESO. Okay, it's not Durva. It's the other drug approved in extensive stage small cell lung cancer. The goal is the same. Can you give chemoradiotherapy and then in limited stage small cell lung cancer and then use immunotherapy, in this case, at TESO or not? But some differences here, right? In this trial, patients could have received one round of therapy before they started, but this was really designed to be in patients who were getting their combined chemoradiotherapy, and then they got randomized while they're receiving that. As they were about to receive that treatment, they could have started some chemo first, and then the atezo in this case begins early. So this begins with the beginning of the second cycle of chemotherapy. You also only do it for 1 year, not 2 years. There was no placebo here. So it's a similar trial, but it's different in its design. And what we heard in a press release is that this was a negative study. And so more to come, but, kind of interesting that didn't pan out for atezo in this trial. But, again, a very different kind of study than the Adriatic trial. Let me shift to kind of where are we? So I was recently in a meeting and somebody used the expression, well, this is the decade of small cell lung cancer, which was kind of a little comical to me because small cell lung cancer, nothing's really happened in probably 2 or 3 decades besides platinum etoposide. I mean, we've learned a little bit about PCI use, concurrent radiotherapy, and of course the immunotherapy approvals in extensive stage disease. But then we got this Adriatic trial, which was exciting. And then we got this. So this is a drug that just was FDA approved, May of 2024, that it's important to know about because this is a big deal. And what we don't know is where else is it going in small cell lung cancer treatment. So tarlatamab is what's called a bispecific antibody. So like it sounds, it targets 2 things. It targets something called DLL3, which is the antigen expressed on small cell lung cancers. It's pretty ubiquitous. And so this is not something you have to measure or test for, although there are some efforts underway with compounds in this space to see if expression matters. But in this case, this approval was based on all patients who simply had small cell lung cancer. And so the other part of the bispecific is that it targets CD3, that is the antigen expressed on T cells. And so I explain this to patients this way, that this is very different than a checkpoint inhibitor, right? A checkpoint inhibitor releases kind of the checkpoint or break on our T cells, and you hope that they wake up and kind of figure out what to do. With a bispecific like tarlatamab, what you're doing is you're reaching out and kind of bringing T cells in the proximity of a small cell antigen and hoping that leads to cell death. And it seems kind of insane that works, but it does. And this is not the only example of the success of bispecifics in oncology. But this is a great step forward. This approval was based actually on a single cohort study that the FDA thought would justify an accelerated approval. Actually, my colleague Melissa Johnson was involved at our center in helping lead this effort for tarlatamab, and so a very big achievement, I think, in small cell lung cancer. And so here is why I want to bring this up. So this is on the market in the relapse setting. So for patients who've received, in the case of limited stage disease, chemotherapy, radiation, and recur, or in the case of extensive stage disease, chemoradiation, actually in both cases now immunotherapy, and have recurrent disease, tarlatamab is now available. The question is, if this drug is so good kind of in the relapse setting, couldn't it be great in an extensive stage setting, first line, and that is in studies now? Or what about limited stage disease? So before Adriatic was presented, it's important to know that this trial, this design I'm showing you here, was already kind of designed and underway and basically fully enrolled. And so this is a study of limited stage disease where patients, like in Adriatic, receive chemoradiotherapy, a global trial. But instead of getting durva or atezo, in this study, you got tarlatamab, and it was a placebo-controlled trial. And so this is interesting because if you were going to put pen to paper today and design this study, you would have to consider having durva, at least in the places where it's approved in the US, in the control arm, because that's a new standard. But this trial was conceived, conducted, enrolled at a time when, of course, we didn't know Adriatic's results. So this study will read out, we hope soon. And I mean, it seems like one you'd bet on, right? This one, if durva worked, this should be positive too. I think it's going to open up a lot of questions, right? Like, what do you do when you have a patient in front of you? Both have pros and cons. I didn't talk to you at all about tarlatamab's, how it's administered and how you have to have, at least for now, observation periods for cytokine release syndrome. But you can get through all that, and it's a very effective drug, and by and large, a very safe drug. And I think this is going to make a big splash too in the treatment of small cell lung cancer in other settings, first line and in limited stage. So I just wanted to mention a few other emerging modalities in the treatment of small cell lung cancer. And again, I think this would be focused first in relapse small cell, but hopefully eventually in earlier stages of disease. So the first and the third bullet points here are actually focusing on a class of drugs everyone's very familiar with in a variety of cancers, breast, lung, bladder, and that is antibody drug conjugates. These are finding their ways into many different cancers, many different treatment settings, and I think have been a major advance, obviously, in oncology. But in small cell lung cancer, we're seeing some excitement too. There's some early development of a drug from AbbVie, 706, that is targeting, kind of like DLL3 with tarlatamab, targeting a unique epitope in neuroendocrine cancers. It's SEZ6, and so we'll be watching for data on for this agent using a topoisomerase payload. And this may be a drug that has a role in other neuroendocrine settings. And then we've seen some compounds, particularly from Daiichi, presented in small cell lung cancer relapse setting, the B7H3, TROP2 directed ADCs. And so, not only exciting data following, say, oncogenic driven settings like EGFR mutated settings, but in small cell lung cancer, this could play a role in the relapse setting. So I think, whether it's these drugs or others, I think it's not a stretch to imagine that we're going to have at least one, if not several ADCs in the treatment of small cell lung cancer in the future. And the other thing I wanted to mention is lurbinectedin, or Lurbi, a drug that has been on the market for several years now in the relapse setting. It's unclear how its role will be maintained, I think, in the setting of tarlatamab's approval. Tarlatamab can't be given everywhere because the CRS monitoring, at least for the moment, and the need for hospitalization. But Lurbi is still around. And so we received kind of a press release from a trial that looked at it looked at chemotherapy with platinum etoposide and atezolizumab, a standard of care in first-line small cell extensive stage treatment. And patients were randomized to continue atezo maintenance or to get atezo with lurbi. And all we know is this study met its endpoint in a press release, but I expect, over the next several months, we'll get to see the data at a conference and in publication. And so, that could move lurbi earlier in the treatment paradigm, which whether that becomes something docs adopt, I think will depend on what the data look like. But those are some changes that I think we'll be looking out for in the near future. It's great to see some advances in small cell lung cancer, and probably more to come. So just showing the NCCN current guidelines, these change pretty frequently. I'm not going to read through all these, but just to show you with limited stage disease, we're still trying to cure people. We're still trying to always consider, is there something that to justify an operative intervention, and if not, local regional curative intent therapy with chemoradiotherapy, and again followed by durvalumab, now an FDA-approved option. So let's just finish with a case in our remaining time here. This is, I think, a good case to discuss several of these issues. This is a 72-year-old woman who presents with limited stage small cell lung cancer. You kind of do the workup with MRI of the brain, CT scans, often PET scanning when you can get it in the hospital, and you establish a diagnosis and kind of rule out distant disease. That's basically how you define small cell. This patient has some comorbid issues, hypertension, COPD, and was symptomatic with cough and shortness of breath. I think a very typical way patients present with both limited and extensive stage disease. Imaging found kind of bulky mediastinal disease. And again, you don't have any evidence of distant disease. So what are the treatment options we think about in a patient like this? Well, just going down the list, do we think about surgery? No, we don't think about surgery because of bulky mediastinal adenopathy. In fact, it's hard to know who to operate on when you have limited stage small cell lung cancer. I mean, often it ends up being a small lesion that gets resected and then you discover it's small cell. But sometimes you find out it's small cell up front and you can debate the benefits of surgery. Again, I think surgery has a clear role in very early stage disease. With nodal involvement, I would argue that's pushing things just because of the high risk for more extensive involvement. But certainly chemoradiotherapy is what we talk about. Platinum etoposide, I think we've talked a lot about the schedules, the choice of platinum drugs. I think it's fine to use kind of whatever you're most comfortable with. For what it's worth, I give daily radiation and I give carboplatin etoposide. I will tell you, my goal is always to start cycle 1, day 1, but it's easier to say that than to do it, just because of the way patients present and when you want to get things ready to go with treatment planning. But I would tell you it's ideal. It's also hard to pull off, if it not just with scheduling. I mean, just in terms of getting through it. In my experience, I think it's ideal to get chemotherapy started to get control of the cancer. It's very effective, as a high response rate, probably north of 70%. And getting radiation kind of started as soon as you can is ideal. But I kind of like to come in almost at the second cycle and kind of have radiation go through cycles 2 and 3 and finish with chemo. The worst thing that it can happen, and I've had this happen, is you start both and you don't get to cycle 2 because of toxicity and other issues. And then I think you lose opportunities to cure patients when you disrupt therapy like that. But if you can get somebody in from day 1, cycle 1, day 1, that's great. We all kind of fear sequential. We think like we're doing something bad if we have to separate radiation from chemotherapy. But it's okay. I mean, if you have to do it, you have to do it. It's better to get those things in than not get them in at all. And so, yes, there's a slight advantage for concurrent therapy over sequential, but sequential is pretty good. And so don't abandon giving chemotherapy and or radiation because you can't give them together. If you have to give them apart, that's fine. And then we talked about immunotherapy. So getting somebody through those, kind of waiting for them to hopefully recover from everything. And, being aware of radiation pneumonitis and then using durvalumab. And remember, it's for 2 years. It's not for a year like we think about durvalumab with stage 3 non-small cell lung cancer. To address some of these other issues, how do we think about planning, selection, delivery? I think we've kind of addressed those. It's pretty wide open with choice of platinum and schedule of radiation, and the there's even patients, I didn't get into this, who got less than 4 cycles, but the goal is to get in 4 cycles of treatment. How and when should clinicians plan for kind of giving durvalumab? I didn't talk a lot about that, but the study allowed up to about 42 days. But there's no magic to this. It's kind of like non-small cell, stage 3 disease. I think if you can start sooner, there's no reason not to do it. If you have to start later, that's fine too. It's usually because of the toxicities of their combined modality therapy, and it's usually radiation pneumonitis. And so that gives me pause. I think you just have to be very careful and clear about what you're starting with in terms of baseline pulmonary status. I think the worst thing we can do, and I've done it, is jump right into immunotherapy when somebody hasn't really kind of literally caught their breath after finishing chemoradiation therapy. It may be that you can't give it because patients have too much pulmonary toxicity from their radiation already. And so you just have to defer it or postpone it or stop or not give it altogether. PD-L1 status, we haven't talked about that. That's been a little bit controversial with stage 3 non-small cell lung cancer, where the approval was based on Durva in everybody, but in the European regulatory authorities required PD-L1 expression to give it based on some post hoc unplanned analyses. In Adriatic, the small cell limited stage study, PD-L1 status was not a requirement. There will be some subsequent kind of analyses looked at, but it was not a requirement to get on the study. So it's not a factor that's used in the label or deciding who to get it. We talked about PCI use. And then this other question, can you re-challenge with immunotherapy after progression on Adriatic? I think that's an interesting point. We've been dealing with this since Pacific first came out in non-small cell. And we deal with this with a lot of cancer settings where you treat for cure and patients recur. Like, should you use that therapy again? I think it kind of depends on how long it's been. I mean, if I gave somebody 2 years of Durva and then I stop it in the next short period, they show up with more small cell lung cancer, giving them immunotherapy again doesn't feel like that's going to be helpful. If I gave somebody any amount and we stopped it, and then a long period went by, what is that length? Is it 6 months or 12 months? I think it's probably something that's closer to 12 months. And then cancer shows up again, I absolutely would try immunotherapy again, maybe Durva, maybe something else. So I think it kind of depends. How do they do? I mean, first exposure, how long did it keep cancer away? How did they do from a toxicity standpoint? How much did they get in to make that decision about whether it makes sense to give them more immunotherapy? I think it's going to be really interesting if tarlatamab finds its way into this paradigm about, if you use tarlatamab, should you use that again down the road? And how do you mix these drugs or use them sequentially or even together one day? And then finally, what are unique safety considerations associated with use of immunotherapy? We haven't really talked about that because the safety profiles really look like what we've expected with both atezolizumab and durvalumab in extensive stage settings. There's no real surprises there. I think the best comparison to me is the Pacific trial with Durva following chemo RT in stage 3 non-small cell, because the radiation pneumonitis questions and serious toxicities related to that look pretty similar to Adriatic. In other words, it is a safety concern, but the rates are very low and manageable. And again, as I was saying earlier, I think radiation pneumonitis is probably the biggest concern. And you need to kind of think through, how am I going to follow this? If I start durvalumab, what am I watching for? It can be tricky sometimes with a scan that already looks kind of messy before you give your first dose of durvalumab. And remember, you may not even want to give durvalumab if patients are really, already symptomatic from the radiation, and you've waited and it's not getting better. Giving immunotherapy is not going to be a good choice. I think that's it in terms of this case. So I think we would give chemoradiation therapy here and then followed by durvalumab and watch closely. Maybe one last thing about this, and again, this is just my unique and probably strange approach. Because I don't use PCI routinely anymore, I do a lot of MRIs of the brain, and that's not feasible everywhere. I get that, and it can be hard even in the U.S. with insurers, third-party payers. But I try to. I try to always look. It is a common area for recurrent small cell lung cancer, and if I see disease, I go after it, right? And I try everything I can to spare patients whole brain radiation. I'll do it if we have to. And they want to, but we try to pick off spots too if we can. That's become a trend, I think, over the last several years that I think has been great for patients, even if they have to get multiple rounds of radiation in a limited fashion over the years. Okay, some take homes. The main one is that durvalumab is a new standard of care, as I mentioned, in patients following chemoradiation therapy for limited stage disease. We just talked about PD-L1 status. I didn't mention other markers, but the bottom line is we don't yet and may never have a selection marker for the use of immunotherapy in this setting in limited stage disease. We certainly don't in extensive stage disease. I wish we did for some of the things we do, but we don't at this point. And then the other thing that's kind of a caveat to this, because it is different in how we think about curative intent therapy in lung cancer, but this is 2 years of immunotherapy. So that's quite a commitment from patients, but once a month for 2 years, hopefully can be something a lot of patients can manage, particularly with the advantages for survival and progression-free survival. So with that, I will stop and appreciate your time and attention, and very excited for kind of our patients and families who have this new advantage and step forward in small cell lung cancer treatment. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/ZPF860.